to be a half-hour workshop. When I heard the workshop, I thought I'd make it a bit interactive. So there is a little exercise in the middle where you can talk to each other and share your views. I'm Bill Freeman. I'm the Chief Executive of the Community Transport Association. We work with thousands of charities, community groups who are an independent network of providers of transport covering just about every local authority area in the UK. And they all provide transport for what we call a social purpose and community benefit. They're all not-for-profit, and health transport is a big area of work for that group of operators. I'm sure if you're working at a local level, you will be familiar with some of those in your area. Can I just have a show of hands? Everybody in the room, do you commission transport services? Do you organise patient transport? Give us a wave. Are you just here because you like talking about transport? Okay, so some of what I'm going to talk about you probably may know already, but it'd be good to just get a bit of a recap. Some of the things we do as a national body is try and raise the visibility of the work our members do in the health service, but we also have a wider interest in transport systems being good and being accessible and inclusive. So we get involved in discussions around non-emergency patient transport, government bus strategy, and all things like that. So, in my 30 minutes, and hope that big red thing's to remind me not to go on too long, I'm going to look at a few things, some of the facts and figures, things we know about non-emergency patient transport services. I'm going to look at the recent review of, well, it came out recently, it started at the end of 2019, of non-emergency patient transport services. Another opportunity to give me a wave. Is anyone familiar with that report which came out in August? Put your hand up. So there's a few people are good. That doesn't mean all of that. Those things I've got to say about that are totally wasted. So we'll just do a bit of a recap about what's in that report. Obviously, we've been working very differently in the last 18 months or so. So we're going to look at what some of the learning from that is, and hopefully all the way throughout there'll be some tips and takeaways that are useful to you. So, some facts and figures. We know that there's, and this all comes from the non-emergency patient transport report that came out in August. So there's about just under 12 million journeys taking place each year. If you look at the breakdown of those, so for out of every 20 journeys, most of those, just under half, would be taking people to outpatients appointments. There's a significant chunk taking people for renal dialysis, and then some would be discharges and transfers. One of the other figures that stood out at me was about the number of journeys that get cancelled. And there's obviously in the report, it talks about the various reasons for that, be that cancelled by the patient themselves because they've found alternatives, appointments being moved, transport not being available. That is a significant sum if you look at the total number of journeys being made in the year. About 1 in every £275 spent by the NHS is spent on transport. It's 38 quid a journey. That sounds quite a lot if you consider what folks spend to get a bus or a taxi. That seems quite high. Obviously, some will be a lot more than that and some will be a lot less. That's a significant spend. And as with many reports these days, we also have to talk about the carbon footprint of working in a certain way and identify ways in which we might reduce that in the future. So we got this report, but it came out, as I said, at the end of 2019, and there's been various reports from different charities, Age UK, Kidney Care, some that we've done ourselves, that was asking the question, you know, how could these things be different and better? What is it that doesn't quite work for you as commissioners of services, for providers of services, and most importantly for the users of those services? Probably the most significant piece of research came from a report that Healthwatch England did that came out in October 2019 that spoke to about 30,000 people, and 9 in 10 of the respondents to that said that transport was a significant factor to them in their quality of experience, how convenient it is being able to get to and from a healthcare appointment. And they identified particular groups who were most difficult to serve, those in rural areas, those that needed to be accompanied, and some of the issues that was raised there led to the NHS Chief Exec, Simon Stevens, at the time, saying that there would be a review. And a panel was put together of various interest groups that started its work just before the pandemic, and then we had to wait until August this year to see the fruits of their labour. So what the report is saying there's going to be is a new national framework for non-emergency patient transport. That is going to have a number of components to it. There is going to be updated national eligibility criteria. There is a live public consultation at the moment that closes on the 25th of November, which is looking at how we judge whether someone is eligible to access patient transport, and perhaps what we do with those people who aren't quite eligible but still need some support nevertheless. Like with many reports about how do you improve systems, there's also a focus on technology, and particularly how technology can improve the coordination and the information that's provided to people as they wait for their journeys, and looking at, you're going to have a range of provision, not be solely reliant on one or two models, but actually have a more diverse range of providers. Then how do you coordinate all that? And technology is obviously a significant component of being able to do that well. They also commit to having that more comprehensive transport support. The four elements they see or the four components of patient transport they see is, one is that coordination and triage, so how do you work out who's eligible and then get them the right journey. There's the specialist transport that's provided by the providers of non-emergency patient transport. There's what they also call non-specialist. My members would look horrified if they thought they were being described as non-specialist transport providers, because what they do is very specialist, but in this context it's to juxtapose them with what the ambulance service would do. And that also includes taxis. And then the fourth component is reimbursement, so where people aren't going to be provided with the journey but may be able to have some of the costs of making their own way there and back. So what they want to do and advocating for in the future is actually you've got more of that non-specialist journeys being provided, not being solely reliant on the formal non-emergency patient transport. There's also something in there about improving procurement and contracting, and looking at various ideas for how that could be done differently. They want it to be net zero by 2035. There's different ways you can do that. Clearly, the fleet, and whether that is an electric fleet, is a big factor in that, but not the sole issue. And as many more things, public transport, taxis, other forms of transport, all become a bit greener, and we move to having different kinds of fleets, then that will create pressures in systems around charging and storage facilities, and it will alter the way in which you plan services, and that's going to have a massive impact. We've got, how long? 14 years to sort it out, so we shall be fine. And all of this is going to come under the auspices of the integrated care system, so they will assume responsibility subject to that all going through as planned. They will assume responsibility for non-emergency patient transport services. So obviously the report came out during the pandemic, and whilst they were when they were developing the report, they were focusing on the things that they learnt through the consultation exercises they'd done at the beginning of 2020. They also wanted to reflect on, well, what have we learned during the pandemic about patient transport, how to do it differently, how to do it better, what works, that we want to take forward? What were those things from the pandemic that should influence and give us some ideas about what comes next? So I'll share in a moment some of the things that the report focused on. I thought, given that it's a workshop and you're getting ready for your lunch, I'd get you to have a chat about it first. When I was planning this, I didn't know whether I was going to be in some little room or whatever. So I think the best thing is if you just have a quick chat with your neighbours. And what I want you to do, we're going to spend a couple of minutes on this. What you want to do is think about patient transport, last 18 months. You don't necessarily need to answer these questions, but what I want to hear from you is there anything you've noticed or anything you've had to do differently that you think, yeah, we should try and do that in the future? That should be how it should be for always. So what was different? What worked well? Which of those things that you've seen in the last year you think, yeah, we should take that forward, that should inform what we do in future? Or it might be something that didn't quite work and you think, okay, if we were going to solve this in future, what would we do? So just find a neighbour. If you're sat on your own, maybe move to the next table, stay socially distanced if you wish. And I'll give a couple of minutes for that, and then I'll send a mic round, or probably end up bringing a mic round myself, just to get one or two insights from around the room. Everyone all right with that task? Yep, good, thank you. Right, everyone. Okay, if we all come back together as one big group, I'm going to pick on some tables. I was just a quick feedback from anybody that wants to tell us what they've been talking about. This table, anyone? Want to volunteer? On the mic?
Not that I know about any PT.
Okay. So say who you are and where you're from. I think it's already on.
Hello.
Yes.
Hi, I'm Catherine. I work with ISS Facility Services, so we do some NEPT. I think the thing we were talking about was I'm really surprised at the number of aborted journeys, and surely with the technology, and we were talking about trust systems and healthcare systems talking to NEPT providers directly. So for patients, appointment gets moved because that probably happens quite a lot, that there's a link into the NEPT service and that's linking into the patient. So I think there's something there about technology, and we all understand how challenging it is to get different systems talking to each other. I always think it's very easy because you just be able to push a button, it should happen, but it doesn't. So I think there's something there. So we were really surprised around that wasted resource, and it's not just the money, it's the manpower and everything else to do that. And I suppose eligibility, I think there's still, there's a lot of work to do there with maybe we're becoming, people depend on NEPT, they go to that first rather than maybe looking at another way of getting to the hospital when they can. So I think there's a lot of work to do there. We were just talking around that really, weren't we? Yeah.
Morning everybody, it's Eileen Phillips here from Greater Manchester Mental Health. Thinking about the last 18 months, what was different, I suppose for us it went very, very quiet in terms of patient transport because all of our wards were closed. We have an awful lot of forensic units again, so actually the demand went down in the very, very early days. What worked well for us, we had to put in quite rigid cleaning regimes for when we did have to use the patient transport. We had to put an awful lot of thought into how we would manage escorted patient transport. And again, from our high secure and forensic mental health units, that caused us a little bit of thought in terms of changing processes. What worked well, I think every NHS trust just stepped up and we looked at new and innovative ways of getting things done, and long may that continue. What should inform the future? It's all about net zero, it's all about electric vehicles, it's all about using technology and changing cultures, I think, going forward.
Super. Do you want to come and finish off my presentation? That was excellent.
I think what we'd like to add to what's been said, and that's, it's covered most of what we've covered as well, but one of the big things we raised was, I'm from North Wales, quite a rural area, versus my colleague who's from a London Health Trust. And it's really not around COVID, but it's around the issues now where patients will have multiple appointments at different hospitals. It could be the case that actually the non-emergency patient transport vehicle is actually following the patient around the different hospitals to make sure that they actually get to their appointments. But I think the conversation in regards to COVID is very much around We've had a lot less activity in our hospitals, so obviously that has had an impact over the 18-20 months in regards to non-emergency patient transport. But one of the things that we adopted quite early when we looked at NEPT was in regards to out of hours services, and we were an early adopter of the 365 model, which is, if you've not heard of that, it's like an Uber type service, which is provided through I think it's 365 Response, based up in Yorkshire. So there's a lot out there, a lot of change in regards to non-emergency patient transport, which I think is going to make it a very bright service for the future. And it's been somewhat a kind of a satellite service, very much behind the blue light services for a long time. And I think we've gone through some fantastic change in regards to non-emergency patient transport, especially Wales, with the Welsh Ambulance Services taking on all the services for us. So, I think it's got a really bright future as its own service in the future. Thank you.
Hi, I'm Lee Peddle from CNWL, London Trust. We've got mental health services and community services. So we've got secure transport, NEPTS in both inpatient and outpatient. Obviously, like many have said, the activity plummeted at first, but we got our contractor involved in a lot of the other stuff that was going on around medical couriers to use some of that capacity, and also supporting with the schools vaccination program and the vax hubs that we were running. So that's really helped. But probably the biggest difference that we see, potentially we'd like to make a permanent one, is we picked up the Section 135 transport from London Ambulance Service because they needed the capacity for acutes, which is something that's worked really well for us in that we've had some really positive feedback from the police about it. So I'd like to see that embraced as a new model going forward. But the biggest challenge we found is obviously the social distancing element, and as things go back to normal, how we're going to be able to cope with that. And in terms of informing future practice, we hear a lot about the new normal in terms of outpatients particularly, and I think PTS has to be ready to respond to that. There's going to be a very different model going forward for how that's going to work, particularly in outpatient services.
Well, some brilliant insights there. Thank you. Really appreciate those. And good to hear that there's some thinking going on about what does the future look like. So what did the actual report itself highlight as some of the things that had been seen during the pandemic? One was that greater level of coordination and actually providers and being able to manage capacity between them a bit better, and a more collaborative approach within that. Actually working with a greater variety of organisations, some of the charity home from hospital type services and some of the sort of volunteer based stuff. So I think that that is something that goes forward to the future. There was this idea of responsiveness as well. As we had to introduce social distancing, people were getting more personalised journeys. So actually, the quality of experience some of those passengers had was much greater than they might have had previously, because the minibus or the vehicle wasn't necessarily picking up several people on the way and they weren't sitting on it for a long time. So we're getting quite a personalised service, and again, that's something people really value. And we know from the work that community transport does, that's kind of personalised approach, services being tailored around an individual or a small group of individuals, does lead to benefits for those people, but you've got to weigh up the costs of that and find efficient ways to do it, if that is what people want in the future. Again, these new forms of partnership, diversity of suppliers, we got rid of silos and we worked across organisations and across sectors, and that was really powerful and beneficial. And I think, again, if we're going to do things differently in the future, finding ways when we're commissioning services to actually encourage and incentivise that kind of partnership approaches within provision would be really strong as well. And it also talks about new forms of civic engagement. Obviously, there was a lot of attention given to the Good Sam app, so the NHS Volunteer Responders app. A lot of the work that was done through that wasn't really transport focused. I mean, we had some concerns about it because, you know, we had this ready to go army of community transport providers all around the country, but who were all saying we can help, but you know, they'd have had to have got their individual drivers signed up to the app and got kind of anonymous requests through that. So it didn't quite tap into a lot of the local resources that are already there that the NHS can benefit from. You know, it doesn't quite work to have this national clearinghouse and call centre for mobilising local volunteers. So it didn't quite work in the transport space, but there was certainly a lot more interest and involvement around communities in supporting the life around health settings, which was really important. And we certainly did our bit to get more community transport operators working within health. And that's something I'm just going to touch on before we end. And this is some of the benefits. So does anybody work with local community transport operators in your area at the moment? Are you aware of them? Do you have any relationships with them? Give us a wave if that's the case. So this would be local dialer rides and volunteer car schemes and that sort of stuff. Anybody got a wave there? Great. Well, let me tell you why that's an important thing to work with community transport. So a lot of our services would be minibuses, volunteer car schemes, dialer ride type services. The second most common destination for a community transport journey is to a health setting. That could be a hospital, a clinic, community-based services. Also, social services would fall within that. So it's a big area of work for community transport providers. And their core users would be people who often find themselves generally within the scope of eligibility for using patient transport, but maybe just outside, but still need some help. So a lot of referrals they would get would be people that have tried to have access to non-emergency patient transport, haven't met the criteria, and have been sent somewhere else. And I guess what we'd like to see in future is the sent somewhere else being a bit more coordinated, so actually these organisations have proper relationships in place. You know, we had some figures from research a couple of years ago which found 74% of the operators in England were taking people into health settings, but only 24% had any financial relationship with an NHS body. That's great if you've got a commissioner, you've got people doing free work for you. But if the money and the rewards weren't there, chances are the relationships weren't there either. So some of that referral wasn't quite working. And people weren't able to manage the demand that was being placed on them with people being sent in their direction if they didn't meet net. So, you know, we've got that network there, and I think we are going to see some innovation in how services are commissioned, and we're going to have more of the supply chains put together with maybe a prime operator and some more community-based organisations underneath them. There's real potential to tap into some of those networks that exist in your areas that you're probably not working as closely with as you could at the moment. And they're pretty well plugged in. So actually we did a survey last year where we were trying to find out who had some spare capacity to help out. If you got a call from the local health service, who could actually say, yeah, I can help? And a lot of them were saying, well, we wouldn't need paying for that because we've already got a contract with the local authority for providing dialer ride type journeys. So actually we do it under the auspices of that. Again, that's not necessarily something a commissioner should think, yeah, free work for me, but it suggests that actually there's a lot going on in local transport at the moment, which is trying to integrate things more. You know, we've got a national bus strategy that's trying to look at how you have a whole network approach in an area. That will influence public transport routes into hospital and health settings and influence some of the types of services that exist around patient transport. If you think about it, a local authority is commissioning all sorts of transport, and you know the real prize, which we explored a few years ago in a project called Total Transport, the Department for Transport ran several pilots around 2016, was this approach called Total Transport, which actually, how do you integrate the commissioning of services in a more joined up way? You know, you've got local authorities commissioning loads of transport services, you've got health bodies doing the same. Is there a better way of coordinating that? And that's not suggesting that you have one big contract with the lot to supply everything. It's trying to get that creative and collaborative approach to both commissioning and provision which was my title. So how can we help? We're a national organisation. We don't provide anything ourselves, but actually we do brokerage. So if anyone ever contacts us and says, you know, from a health board that says, or a health body that says, we want to know what's going on in our area, is there any operators we can talk to? We can make those introductions. Some final thoughts, just to give you some examples of some of the ways in which we can be creative. 2 examples from Wales. You were from Wales, weren't you? So these are from Wales. We've got, this is an interesting one, the one on the left. This is a small grants programme, it's £10,000. And, you know, it's not an insignificant sum, but actually it's going to be transformative to some of these organisations. This is where a health board in Wales has said, well, actually, we just want to supplement what we're obliged to do with some additional services. So there's grants available for local charities, social enterprises that are going to make, and it's about making themselves more sustainable so that they can help people reach hospital and health settings. And then the other example, again, is from Pembrokeshire, Pivot. It's Pembrokeshire Integrated Voluntary Organisations Transport. I think it's one of them where they came up with the acronym first and then made it fit. This is a range of charities. You've got British Red Cross, RVS, the local community transport providers, who are all working together to provide a home from hospital service, which is reducing delays in transfer to other settings or to home. And actually, you know, that image is from a couple of years ago when they were first starting out, looking at how they were measuring, you know, preventing hospital admissions by supporting people in their homes, able to support easy discharge, so getting people out of hospital beds into their homes. The transport providers would help, and actually at the other end there would be other charities that would provide some of the ongoing care, and they were able to monetize how many bed days they'd saved as well. So there's just a couple of examples of some of the things that can go on if you're thinking about some of the small differences you can make to get in some quite massive impact within local settings. So that's me. I'm conscious I've run over slightly. I'm getting a thumbs up to tell you to go for your lunch. Did anyone have any final questions? Probably I'll stay here, and if you want to come and chat, that might be the way to do it. Is that the way to do it? Yeah, rather than keep them any longer. You'll want your lunch. Thanks for coming along to this. I hope in 30 minutes I've been able to spark some thoughts in your mind and things you want to go away and think about.